Welcome to the Resilient Performance Podcast. This is Keep It Real 38. We have a special guest on here with Trevor, Doug, and myself. We have Zach Baker from Rehab to Perform. We have a whole bunch of stuff we're probably going to just go on tangents and talk about. But first, before we do any of that, Zach, why don't you just kind of give our listeners a quick intro? I think probably a lot of them probably already know what you guys are doing, down in the Maryland, Baltimore area, DC area. But if you could kind of just intro what you guys are doing and who you are, that'd be awesome. Thanks.
Yeah, thank you, Greg. And I'd agree. I think we do share a lot of similar professional networks with who we interact with and who we come across. I appreciate a lot about what you guys do. And I think what you do at Resilient is very, very similar foundationally to what we value and what we practice at Rehab to Perform as well. For individuals who I haven't met or haven't gotten to speak to, I'm Zach Baker. I am with Rehab to Perform. I'm a physical therapist there. And I've been with Dr. Josh Funk since day one when he actually opened the clinic just a little over 7 years ago. So it's been a fun journey where I've got to see the practice grow from just the two of us operating out of about 1,000 square foot space, subleasing from a larger strength conditioning facility to what we have now, which is currently 6 separate locations ranging 3,500 to 5,000 square feet in the greater DMV area throughout DC and Baltimore. So my day-to-day, I treat about 30 hours a week. And then the remainder part of my week is geared towards serving as the program director for our sports residency, which we're currently in our first cohort of completing. And then I'm also actively involved with a lot of our community outreach and networking initiatives that we have with the local public school systems, where we actually go out and guest lecture at the sports medicine classes that they have there, actively involved with our clinical internship program and just building out the programming and the content that we have with that. And Jamie Schindler, who's been another one of kind of the originals at R2P, plays a large role with that as well. And then just trying to get out in the community, introduce people to who we are, what we do, try to clear up really what physical therapists do and how we can best integrate from the medical side of things, from the strength and conditioning side of things. And I think also more importantly, when you talk about like the youth, recreational and adult athlete, how can we also help just from the triaging of injuries and make sure people are getting to the appropriate medical professionals, whether it's ourselves or their primary care, urgent care, just kind of help out with where I think the PT profession is moving in the forward as well.
Zach, just because I know that we came on here to discuss a very specific topic that we'll get into in a little bit, but I think to just provide some context for that conversation, I think one of the things that you guys do really well at Rehab to Perform is you've managed to standardize your ACL rehabilitation protocol. And it's easy for like one person to do ACL rehab well, but I think that you guys have managed, I think, and we all admire your ability as a company to do ACL rehab well, especially with the constraints of an in-network practice. So can you talk about just kind of, briefly your kind of like philosophical pillars for ACL rehab and then how Rehab to Perform as a company has kind of made everybody aware of like, here's what it is that we do, and obviously allowing for some individual clinician discretion, but how have you been able to standardize what you do throughout your organization?
Absolutely. And I would argue, or I would just add that we have kind of a living document with our ACL, either discharge criteria or return to sport testing. And it's really a blend of what does the literature suggest, what's commonly accepted, just orthopedic checkpoints. And then I think ultimately, how are we doing an appropriate needs analysis of the individual and the terminal task that they're trying to return to, and making sure that the tests we are selecting are representative of that terminal task they're trying to get back to. And I think if you do a good job of hammering down what you value from a testing standpoint, it allows you to reverse engineer all of your exercise programming. And when you talk about functioning in an outpatient orthopedic sports med environment, you can be in an environment that may be a little bit higher volume or a little bit faster pace. And I think if you have some of these systems and processes in place, it takes away just some of the mental bandwidth that you have to allocate to that on a daily decision making. So what do we value with regards to mobility? What do we value with regards to expression of strength? Whether it is single plane, single joint expression of strength, or we're talking about like a quad index or a quad to hamstring ratio, if we're really diving into more of just kind of the kinetics of what we can produce, compared to some of the more bigger picture stuff from a kinematic standpoint. Maybe we want to look at the expression of strength in a bilateral or an asymmetrical environment. And then how does that translate into some of our more open turf movements? And then ultimately, what are we looking at from a physical fitness and just general conditioning standpoint as well? So I think as a company, we really sat back and figured out what are our non-negotiables that we think need to be expressed by every athlete just to have a functional baseline to say, we're communicating the same thing that the orthopedic world is in regards to tissue healing timelines, expectation of just overall healing timeframes, but then really going into our wheelhouse as, PTs and strength conditioning professionals, how do we adequately evaluate movement? And I think more importantly, not only how do we evaluate that movement, but how do we synthesize that information and figure out what tests are going to provide us with that information? And more importantly, what are the shortcomings or limitations of that test? Because there's no single gold standard test. And how can we hedge our bets by finding something else that's going to match up well with that? And I think kind of the three pillars that we look for clinical testing, it should be valid and reliable. Do we have research? Do we have evidence that has any sort of bearing on this being a meaningful test? Unfortunately, we don't live in a world where there's just an abundance of research on every single demographic that you're working with. So then I always say, is it practically applicable? Does the test pass the eye test? Is the task you're doing in the test consistent with what you're trying to get them back to from a terminal task standpoint? And then I think the third and most important part is just the logistical feasibility of that test. We all know that Biodex is kind of the gold standard for isokinetic testing. I don't know too many people that have one sitting around in their clinic. And if they did, I don't know how many times you could churn a patient through that and keep up with the practice of the day. So we look at all of our clinical tests as kind of a triple Venn diagram of those three different categories. You figure out the tests that you have, how many of those three does it hit, and how can we supplement it with other tests in our battery to make it more valid and reliable, to make it more logistically feasible or more practically applicable.
Cool. And so with that background, I'll kind of lay the groundwork here for what we want to talk about, and then we can have our we can spitball. So how this came to be was we were going back and forth in the DMs on Instagram. We saw a video of an athlete at 8 weeks doing some like change of direction work with some lights going off. And then when a light went off, the athlete would touch the light and then catch a ball. And like there were kind of a lot of things going on. And the rationale for it was that like we're training, perception or cognition, and because cognition and perception are important aspects of agility, and that's what differentiates agility from change of direction. And we're not here to have the conversation of like, should we do, like open-ended agility work versus, like closed, fixed change of direction drills. That's just, I think that conversation's been beaten to death, and like we don't have to make that choice. No one's advocating for one or the other, but just so people understand what conversation we're trying to have here, the question is, when is it appropriate to introduce some of those like open-ended agility work into a rehab program? We're not talking about working with like healthy athletes here. It's at what time is it appropriate, and then how much sort of like cognitive load, at what point is cognitive load like the limiting factor in an athlete's rehab? So that's just some kind of general things there. I mean, I think our stance at Resilient is like, until certain physical qualities are developed and trained, these perceptual things are not the limiting factor in performance. So it's like the brain's ability to process information is not what's preventing that athlete from achieving a high output at 8 weeks. It's things like strength. And to us, like if you can't demonstrate that you can hit certain positions and have, produce force, in a very like a closed type drill, what are the chances that now you can do it in a more dynamic and chaotic environment? So hopefully that lays, and then, how much is what we're going to do in the clinic going to really recreate what goes on in the sport? So like, is the clinic even the best place to try to introduce that stuff? Like if we have lights and whistles, and does that really duplicate the game versus maybe focusing more on the things that we can actually control in the clinic and then letting the sport take care of the rest? And that's where I think it gets interesting as to like, what is the best time and place for that? We're not saying that like that, the perceptual work isn't important, but I think a lot of times when people say, okay, we're training the brain, we're doing perception, everybody kind of claps and cheers on social media, but it's like, you still have to do something that's actually good and develops that. And I think a lot of what we're seeing you're not actually training the thing that you think that you're training. And how much can we even develop those perceptual abilities in a PT clinic with very limited resources? And, we can't recreate a small sided game, especially at like 8 weeks. So that's a lot, but I think that's kind of like what we're trying to get at. And then we'll kind of let you take over from here. And then I'm sure from there we can get into the nitty gritty of it.
Yeah, and I like how you touched on movement is multifactorial. And I think when we look at the kinematic expression of movement from a rehab standpoint, we're always looking at what is that rate limiting factor? And is it more kinetic quality? So like you had mentioned, can we actually access a position from a mobility standpoint, from a joint variability standpoint? Do we have the ability to get in and out of a position, either with regards to how the joint can move, soft tissue constraints, things along those lines, swelling, other post-operative conditions? If we can access that position, can we express any sort of force, either from a production or an absorption standpoint? Can we then express that with varying levels of tempo and varying levels of force production with regards to maximal rate of force production or the overall kind of raw force output? And I think if we're looking or we're arguing that we need to have this proprioceptive demands, these neurocognitive demands, and that's the rate limiting factor, I would be much more confident saying that if we already checked off the boxes saying, hey, joint range of motion looks good, soft tissue extensibility looks good, certain joint by joint strength parameters look good. When we start looking at multi-joint strength expression, so maybe going from just an isolated knee extension, maybe to a rear foot elevated split squat or a single leg wall sit or doing some other dynamic task, does that still look well? And the only limiting factor is when we start adding these neurocognitive demands, the movement falls apart. That makes sense to me. But I think what often happens is we do these drills that have a variety of things going on, and we forget about what the intent of the drill was in the first place. And I think the easiest way to put it is the more complexity and the more layers we add to a drill, we're inevitably going to have a lower ceiling with the amount of intensity that we can demonstrate. Mm-hmm. And if we're in a phase, especially early on in rehab, and say we're in like an 8-week for an ACL, or we're in that 8 to 12-week point for a labrum repair for a shoulder, I probably care less about the complexity of the movement that they're able to coordinate and more about, we just need to get raw strength back. We need to get just overall physical fitness conditioning levels, because down the line, if I want to train power is going to be limited by how strong we are. And if we missed the boat early on with how strong we are, we're inevitably going to have some shortcomings with our plyometrics. And I think the further you get from the injury, when you start doing things like plyometric training, you have more moving pieces. You have not only more moving pieces, but they're moving at varying speeds and they're moving at much more complex activities. It makes it harder to discern and differentiate what that rate limiting factor is every time you introduce a new variable. So I think for me, it's really just a matter of like, do some simple things right early on, validate that you've done them right, either through testing or some sort of objective means. And then I always say, like, you get the permission to be more cute when you've already done the basic things right. So I do agree that when you look at neurocognitive demands, and it could be something as simple as dual tasking. So having somebody do a locomotive task as you're having them respond to how many fingers you're holding up, or having them count by 3s or 7s, or having them, it's something simple. Like when I do early gait training with people, especially falls risk, I'll walk them down the turf. Think of like an elderly individual, walking them down the turf. They can do that well. Can they also do that well when they're carrying a conversation with me? Can they do that well carrying a conversation as I'm moving where I am? Maybe I'm walking on their left side or their right side, or I'm having them perceive things from different areas. So they're getting maybe a little bit of cervical motion that's vestibular oriented. You can do the same thing with ACL people as well, whether you're doing a lateral shuffling drill that is more of a constrained drill. And then once they show the ability to do that and express the movement pattern you want, get a little cute with it, modify the tempo, maybe have them perform a reaching task if you want to get through a greater range of joint excursion. Now they're doing that well, let's see if they can do some cognitive demands also. But if you jump right off the bat to the very first thing, it makes it hard to figure out what that limiting factor was. But I do think if you're looking for just organic expression of movement and kind of movement exploration, it is important to get them out of their comfort zone and challenge them a little bit. But if you don't have any sort of working baseline to begin with, you're comparing apples to oranges at that point. You don't really know what you are or are not comparing.
I feel like
I think that's an awesome
chomping at the
answer.
bit here.
No, I think I think that's an awesome answer on a lot of levels, because it's like, I think people, like you said, miss the boat on like the foundational, like to be able to move, people have to be able to express force, they have to be able to produce force. So if you can't do that, there's really no point even trying to do some of the higher level plyometrics and then get in a change of direction and agility work kind of later on within somebody's return to sport kind of process. I always think too, like with the, the kind of video that prompted this whole discussion is, it's like agility in sport is so complex because of different players, team strategy, like all these different, tactical and technical elements of the sport kind of going on. And when you do those, change of, let's say agility drills, because there's the like kind of like light reactive component to it. It's like you're not really mimicking any of the things that they have to do in sport. It's like tracking that athletes do in sport, not just like a light flashing. And then when you're throwing these, implements that they don't even use in their sport, it's like now you're just making things complicated. Like instead of trying to make it complex like a sport is, we're just making things complicated for the sake of making it complicated. So we're not really training any of the true like neurocognitive components that they actually kind of need in their sport. All we're doing is just giving them a bunch of things to kind of process at once, whether it's lights and balls and all these things kind of flying at them at the same time. And that also just decreases the intensity of it. And I think that's like the problem I see when I see so many of these kind of things executed on social media, is it's like, even if it's week 8 or week 28 and they're kind of getting closer to return to sport, the intensity of the drill is so low and the intensity of the change of direction is so low that it's not even close to that terminal task like you're talking about, Zach. So it's like, even if we're doing the change of direction or agility work, if the intensity isn't even relatively in the same ballpark as what the terminal task is, then there's, in my opinion, like there's almost no point in doing it. You're better off just like doing higher intensity plyometrics and trying to get rid of the kind of neurocognitive component of the agility training. And to me, it's like agility should be so reactive. Sorry, that's my dog barking. Should be so reactive in terms of like, more of small-sided game type of things, not necessarily reactive with like lights and whistles and balls and just like, kind of like a stimuli, like overwhelming amount of stimuli coming at somebody, rather than like, okay, in basketball, it's like, I'm worried about the other players in the court and the ball. I'm not worried about like lights flashing and something else kind of drawing my attention that just kind of like comes out of nowhere, like a light turning on does.
Yeah, I think to echo kind of what Trevor's saying, I think the three of us, like Resilient, our approach, like it would tend to be mostly physical. I would think like that would be our sort of main goal, but within that we'll use reactive or game-like situations, small-sided games like Trevor's talking about, to introduce the neurocognitive demand. So I think maybe like the early on, Zach, like your example about walking down the turf and being in different positions, talking to them or not talking to them, like those sort of things. I think that's great. That makes a lot of sense to me, because I think all of us have, walked with somebody who didn't have a steady gait pattern, and just by changing positions or talking to them, I would 100% agree. I'm sure there's research on this that I haven't read, but that definitely makes things more challenging. So I think the ceiling for that then is very low when you're then trying to apply something similar-ish to an athlete who's trying to function at a completely different level in a game situation, like Trevor was talking about, with different tactics and everything, different speeds, like the velocities, the forces are all just completely different. So I think we would kind of all agree on that. And then I'm thinking about like Trevor and I went to this conference and listened to a couple different people talk about, these are like PhDs, like neurosurgeons, neurologists, like people doing some insane research that, I again admittedly haven't read all these people's research, so I have to put that out there. But from what they're presenting, a guy named Damien Farrow, another person named his name is like Alvaro Pascual Leon. I'm probably butchering that a little bit, so I apologize. But essentially, with the science that they're doing with brain simulation and studying skill, it's like, unless it's the same exact thing, it's very non-transferable. So for them, like his example was, if you're kicking a soccer ball, I can't remember what exactly, essentially like if you're kicking like a punching bag or a heavy bag versus kicking a soccer ball, like even that difference in the brain and the circuitry is completely different. So for something that seems so similar, there's not as much transfer as we would hope to that there would be, and be like, man, that'd be nice if that stuff would transfer a little bit better. So just going off of that stuff, I'm always then thinking like, that's always like my end thought is like what these people are telling me, Damien and Alvaro. And I think with that thought in my head, then working backwards, I think I'm just less likely to use a ton of different stimuli in a situation where I'm trying to create some sort of like physical presence with a person and get them to be more strong, more powerful, more reactive. And I think like Trevor was saying, small-sided games, bringing cones in close, getting people to do tag or whatever sort of game you're implementing, like that to me it's still not the skill, right? It's still not playing soccer, playing football, whatever it is. But to me, that's then like closer. And I don't know how much we want to dive into that.
Well, I like what you said about the specificity
Trevor, you're muted.
piece. Because with the specificity, right? Let's be clear about something. Like your brain is always working. You're always perceiving things. There's always some kind of like cognitive thing going on. And I mean, I'm sure there's like standardized definitions of what cognition actually is, but like sports is not cognitive. Like when people play a sport, they're not consciously thinking. They're recognizing patterns, and they should be on autopilot if they're any good. So the question is like, just because you're doing something, you're saying we're working cognition. Like when people do change of direction drills and it's like they have to do math problems while they do it, you literally never do that in a sport. Like you don't even saying like, okay, you're going to run at me if I say an even number go this way and odd number go that way. The fact that you have to like stop and consciously think for a second is so detached from the actual what you do on the field or the court that I think it's limiting your output. And then again, it's like what are physical therapists responsible for? Like in an ideal world, in a physical therapy clinic, we'd be able to like get people who are at the exact same stage in rehab and play small-sided games and do reactive work. Trevor is an animal, and like he can keep up with D1 and professional athletes and chase those people around and have them chase
Not a big
him.
deal.
Yeah,
But like
realistically,
like what should a physical therapist in a typical outpatient clinic be expected to get an athlete to from like let's say like an ACL rehab? And I think if you can get an athlete to do like even very predictable change of direction drills with high intent, and then maybe even some like what Trevor and like Lee Taft would call like a tier 1 or a tier 2 kind of like reactive drill where you don't have an opponent. If you can get them to do that, I think you've done your job very well. But if you're making things overly cognitive where people are literally doing math during a change of direction task, I think you're actually detraining the things that we're responsible for as professionals. So
I just want to add, like what Greg was talking about. One of the quotes that I saved from that talk he's talking about was from Damien Farrow, and he said, "Games should be easy to learn and difficult to master." And like that's something to me that's just kind of always stuck with me, even for when I kind of get into more of like the agility work with athletes. It's like I want to keep the games like super simple, like close space, attack space, escape space, very kind of simple general things. And it's like a game like tag. Like tag is a super simple game to learn, but it's really difficult to master. So trying to keep things in like that realm of it's simple, it only takes a couple directions versus like, right, like Doug said, it's like, all right, if I give you, if the answer to this math problem is even, you're going to go left. If it's odd, you're going to go right. It's like, that's so hard to like actually master after a while. And like you said, the output changes so much when it becomes too cognitive with things that you're kind of just losing the whole purpose of why we're doing like a change of direction or an agility drill in the first place.
And I'll go kind of 2 tangents on that. And I think, Doug, you brought up a good point now your company and the company I work for, we have the luxury where we get to see people potentially from immediately after post-op ACL upwards of maybe a year following the surgery. And we get to do this really cool stuff with them. Whereas some people may only function in an environment where they get maybe 3 to 4 months with this person before they have to tag them out. And I look at ACL rehab, you can think of it the same way as like if I have a baseball athlete coming in with shoulder pain and they're a pitcher, my job is not to break down their pitching mechanics and become a pitching coach for them. My job is to look at, do they possess the ability to express enough total arc of motion at the shoulder to accomplish the task? Do they have total body tri-planar mobility? Does their lead leg have enough hip IR and adduction to follow through? Do they have movement quality? Do they have strength? Do they have all of the pieces to kind of construct this movement that they're doing. And if I check all those boxes, then my next job is to go back to their coach or their pitching instructor and say, hey, this isn't an orthopedic issue. They have good joint integrity. We didn't find anything that's suspicious that they need to go and see an orthopedic to get imaging done or to potentially get surgical intervention. They have all the parts and pieces. They just need somebody to put it together for them. And I think that's how you look at ACL rehab as well, is before we get into some of these gamification of activities, we need to make sure that they even have the ability to put all the parts together to play this game. And if we're trying to have them play a game that they don't have the range of motion for, they don't have the strength for, they don't have the physical fitness for, they can play the game, that they're probably going to play a pretty shitty game while they're doing it. And that shitty game may be because they're not even prepared for it. And I think when we talk about cognitive demands, it doesn't need to be complicated either. So like an example, we talk about lights, we talk about maybe verbal or tactile stimuli. Something very basic that I'll do with people towards that middle and end stage of their rehab, when they've already expressed the ability to do these different locomotive patterns. They've shown me they can shuffle. They've shown me they can crossover step. They can do multi-directional skipping patterns, and they can do a variety of different isolated locomotive movements. Then what I'll tend to do with them, an example of what we may be, we'll be on the turf. We have a 5 to 10 yard alleyway that they're working with. And I'll say, hey, you're going to shuffle down 10 yards till you get to the cone. When you get to the cone, you're going to turn and run to me, and I'm going to bounce the ball. You got to get the ball, you got to toss it back to me, and then you're shuffling back out again. We're going to do 5 of those. And then it can be something as simple as every time you bounce the ball, you bounce it in a different spot. Maybe it's a high bounce, maybe it's a low bounce, maybe it's off to the right or the left, where they naturally have to redirect their steps. So there's that neurocognitive component. They're tracking a ball, like a lacrosse player would track a ground ball, or a DB coming to retreat and then come up to support in the run, and they have to figure out where they're going. So there's neurocognitive demands, but it's specific to the sport, like Trevor and Greg were talking about earlier. And the cool thing you can do with that as well is you're building off previous locomotive patterns that they've already demonstrated competence with. So if they start shuffling and they start changing direction with different strategies than what you saw them do when it was a more constrained task, then we can start to deduce, did the complexity of this drill force them to move differently? But more importantly, does that different movement strategy even matter? Or was it advantageous to the sport that they're trying to get back to from a performance standpoint? And then I think to really get that last layer to it, you can turn that drill into energy systems development. Hey, we did this drill. We're only operating at like 70 to 80% of our overall physical intensity. We did 5 reps of it. Now let's assign a standardized work to rest ratio with it. Now we're going to have 30 seconds rest before we jump into that next set of 5. And guess what? That next set of 5, instead of shuffling, you're going to backpedal 10 yards and then sprint forward. But maybe you're only telling them that in that 30-second rest break, so they have to process it quickly. No differently than going back into a huddle for a football game, hearing the play, and then having to go execute the play. So I think you can really set yourself up for success if you just understand the intent of the drill and figure out how you can have all these little systems, locomotive motion, sport specificity, energy system development. How can you get them to cohesively work together?
I think that's like one of the things that again, I use a ball pretty much with all of my clients just to get some sort of reactive component with it, because it does get them just to find the appropriate repositioning steps. And one of the reasons I think that's so valuable as you go into even if it's just what we consider like a tier 1, where they don't really, there's it's more just like an acceleration. It's not really a true change of direction. Tier 2 might have like an actual change of direction, but they don't know where or when. But it allows us as the practitioner to actually like watch what they do. And if we have the appropriate model of movement, we should know what they kind of like should be doing. And when you see athletes coming off of an injury, like when you only do closed change of direction work and it's predictable for them, they can find very subtle ways to kind of decrease the force that they need to be able to produce or handle on their involved extremity. And then when you see it in an agility drill, they may still be trying to use that strategy, or we may see that strategy pop up. So if somebody has a left ACL, they have to change direction to the right, they may take a way bigger braking step on their right leg to go back to the left. And it's really hard for people to see that if there's not a reactive component and if the intensity is not high enough. So I think we have to be able to get to that point in the rehab, again, kind of, like you said, with the kind of insurance thing, like if you have the appropriate time to be able to do that, that's super, valuable and important. but getting athletes to that point where we can kind of try to tease out, like, are there still these kind of limitations where they are not displaying that full confidence or full output capabilities on that leg, and they therefore have to alter their strategy to move how they need to move on their sports. Like an athlete that is still, limiting what they can do on that involved extremity isn't something I would necessarily want to clear for sport right away. So that's, again, just kind of lets us determine like what are their limiting factors still that may help them kind of achieve that next step in the progression back to sport.
And I would say too, when you get to these higher level activities, or when you get to more of your end stage testing, and Doug, you had mentioned earlier that we have kind of a very systematic way of doing testing with our athletes. I always tell our newer graduates, or some of our employees that are newer to the sports world, when you get to some of these end stage testing, so like things that we'll look at with this is our, whether we're doing hop testing or lateral line hops, or we're doing some of our physical conditioning drills like a 300-yard shuttle, we should never be surprised when we get to the point of testing. And I think if you've done a good job early on of hitting some of the foundational blocks, you're naturally progressing towards that terminal task and towards tests that are going to give you an expression of that terminal task. That if somebody tests out poorly, you missed the boat somewhere from a programming standpoint. If I have somebody that's struggling with a change of direction task, this is probably somebody who also didn't handle frontal and transverse plane load very well with some of our strength training. Or maybe this is somebody that we're doing some plyometric movements with them and they're not able to produce a lot of force. Well, ideally, you would have caught that when you were doing your non-counter movement versus counter movement jumps with them, or when you were going from two-legged to one-legged, or bilateral to unilateral stances, or symmetrical to asymmetrical. If they were doing well with that, then you probably would have caught it earlier when you were doing some of your manipulation of strength. Were they able to produce force? Were they able to do it if you modified and manipulated the tempo and the depth and the position that they were doing the force? So I think, like you said, when we get to these higher end tasks, ideally the only thing that would be limiting their ability to perform it normally, assuming they've already done things previously, should just be either their exposure to that task, and is it a new and novel activity that they just have to explore and they have to figure it out a little bit? Is it a confidence issue? Or I would argue most of the time we just missed the boat somewhere earlier on in rehab, and that's where you got to reassess them, figure out where you need to clean up some of those loose ends.
Yeah, just we mentioned the lights thing, and I don't want people to misinterpret what we're saying about the lights. Like, I think those lights actually for reactive change of direction work can be very good, but a lot of times what we see is you have the lights going off. They're also asked to do math at the same time. They're catching balls while they're doing it, and the lights are like 20 meters apart, and they're doing the drill for like 40 seconds, and it ends up just being like lactic work, change of direction work without a lot of intent. So, like you said, Zach, it comes down to like, what are you actually trying to achieve with the drill? And if you want to use like lights and have them really close together, but if you're having people doing like 20 meters of like lateral shuffling, like a shuffle is just a way to kind of buy space to then do something later on. Like, you're never going to shuffle for 20 meters in a game, like in a lactic state. So, I think our kind of bias is that we want change of direction work, assuming someone is prepared for it. Like, we want it to be done with a lot of intent. And if you're doing it at like very low intensities for long durations, like if you're trying to close space, you're just going to end up in a linear position and you're going to accelerate. Like, you're not using a shuffle to close space for anything more than like a couple of steps, right? So, lights are fine. It's just how are you using the lights? And if we're trying to just, like Trevor said, add complication for its own sake, then we're taking a very powerful tool like these lights, and then we're just, we're not actually training anything of now we're doing like trying to train 10 things when we end up not really developing one thing. And that's kind of, to come full circle, what we were talking about earlier on with what are we actually trying to achieve and how do we constrain the environment to develop what it is that we think is important at that point in the rehab.
And I think when you talk about change of direction, you're really changing direction for two primary reasons. It's either a predetermined task and sport specific skill. So maybe I'm a wide receiver that's running a route. That's something where we want to train change of direction specific to that. Or like you mentioned, we're doing change of direction to reposition our body because we just found we were going one way, we have to now go a different way. And we just need a strategy to reposition ourselves to get to the next point in the most mechanically efficient way possible, which you just said is oftentimes just running in a straight line again. So how quickly can we get to point A, recognize the situation changed, I need to get to point B now, what's my change of direction strategy? Is it a stutter step? Is it a hockey stop? How am I getting set so that I can most efficiently redirect force and then probably ultimately run in a straight line again?
So for you, let's say like traditional outpatient clinic, high school or college athlete, assume that you have, 8 months of insurance coverage. Like what is reasonable to expect out of our profession? Like what are some like end stage parameters where we can say, okay, we did a good job, that we can either like objectively or even subjectively validate, and again, I think like if we can get someone to the point where they're doing even like very predictable change of direction drills and some like, low complication reactive work, and then we have the strength parameters, I think we did a good job. Because realistically, you're not going to have like role players come in and recreate a small sided game in your PT clinic unless you work in like a pro sports environment. So, in an outpatient environment, we have a lot of constraints that we work under, to include like space and equipment and that kind of stuff. So like, what do you, for your staff, like what makes you happy at the end stage of rehab?
Yeah, so I think 5 questions that I always tell people, if you can answer these 5 questions, you can return somebody to sport. And if there is an adverse event, you can chalk it up to just being kind of a victim of circumstance as opposed to an overlook on your side or an oversight on your part. So I think if you can look back at the situation and say, we abided by commonly accepted medical healing tissue timelines. So did we have them sit out for a bony injury or a tissue related injury for an acceptable amount of time? Are they hitting their orthopedic check marks? So this is something as simple as circumferential measurements for muscle girth is probably a pretty good indicator if we did what we needed to from a strength standpoint. Are they expressing mobility metrics, either joint by joint or with other mobility tests? And then also, are they then operating at a level consistent with their pre-injury status? And this is where you get into more of your just general fitness oriented tests. I'll get into that in a little bit. The 4th one, how do they rank amongst their peers? So, hey, maybe they're back to their pre-injury status, but how do they rank amongst the other people in their grade, in their gender, in their sport? Or are they going to stick out like a sore thumb when they get back out on the field with them? And then the 5th one, are they being introduced to all of these in a gradual expression of exposure to where they're not just being thrown to the wolves and going from very simple tasks to high volume activities, or going back from just 2 days a week of PT to 5 days a week with their Division I college team practicing and then playing games on the weekend as well. So I think things that we always look at, you should be able to clear range of motion. You should have, from a circumferential measurement standpoint, if we're talking about ACL, we usually look at mid-thigh measurements. You get their calf measurements in there as well. From an expression of strength, we look at body weight competency. So things that we like to look at is like a single leg wall sit. Can we hold a single leg wall sit at 90 degrees for 30 seconds? I think that's a very good way to get an idea of limb symmetry. I think it's a good way to look at anterior knee loading. And that's a good precursor to something like an anterior step down test, where you're looking at, how many repetitions can somebody step down, anteriorly load the knee, quad dominant movement, but instead of a static environment, in a dynamic, repeatable environment. So you start to look at either muscular endurance or just quality of movement when they go into a dynamic task. From there, we look at tri-planar stability. So we use something like a Y balance or a star excursion test. How does that single leg movement expression look when we get out of an isolated or just a single plane environment and we start doing multi-directional tasks? All of that's great, but it gives you no idea of what their raw expression of strength is. So from there, you can either just have them progressively build back to what their previous strength training metrics were, which I'm sure most of your athletes are going to have an idea of what they could squat or deadlift or leg press or whatever they're using. But we like to look at a lateral box squat to get an expression of biasing one leg in a non-sagittal plane activity. And we look at rear foot elevated split squats. Rear foot elevated split squats, that's our sagittal plane unilateral biased activity. We personally look for 50% of their body weight for 10 repetitions. And with that, it sounds aggressive, but if you think about it, if you have somebody who's 200 pounds 50% of that's going to be 100 pounds. You're working with them over the course of 9 months. You're going to be doing strength training with them, and you're probably starting things such as like body weight split stance progressions in that second month of rehab. So you've got 8 months to build them from a body weight split squat to a 100-pound rear foot elevated split squat. And if you reverse engineer that, the week by week progressions of the weight, if you're doing it consistently, which I would argue with strength training is the most important thing, is just simplicity and progression of volume and resistance, you're going to hit those numbers. So when we look at that strength profile, and then the last thing is we do look at isolated, we use the Tyndek force measurements to look at isolated knee extension, isolated hamstring motion. And then you've got a pretty good strength profile of that individual. You've got isolated quad and hamstring, which there's an abundance of literature. You've got 3 different body weight competency tasks, and you've got 2 different strength metrics, one that's more linear, one that's more frontal and transverse plane. After that, you get into your power and elasticity, something as simple as a lateral line hop. So we're looking at how well can we do a rapid response plyometric activity that has a little bit of side-to-side perturbation, but we've got no demonstration other than just reactive stiffness at the knee of any joint excursion going through the knee. So I think that's when you start to get into things like a vertical jump or a broad jump. And we can start looking at just ability to produce power at a vertical and a horizontal standpoint. You can do that either just with measurements on the floor or with them touching a wall. You can use the My Jump app on your phone. There's a variety of different ways you can look at that. And then you can break that down into either your 1 to 2 footed jumps, your 2 to 1 footed jumps, your 1 to 1 footed jumps to then tease out, is this more force production or absorption issue? Is it more horizontal or vertical that they struggle with as well? Then you can get into your traditional hop testing protocol. And then after that, it's a matter of physical fitness. So we do things simple as what's a self-reported 1 mile run time? What's a 300-yard shuttle look like? Maybe they have a conditioning test that's specific to the sport they're going back to, and they already know what they did with that last season. Well, let's start implementing that early on as well. So that is kind of the standards that we use for ACL rehab, and almost all of those can be done pretty easily in the clinic, regardless of what environment you work in. So I think if you do that with somebody, that gives you an extremely wide movement profile and just fitness and conditioning profile of an individual, that if the numbers make sense and your clinical judgment with their movement quality and movement strategy looks good, then that's somebody that I feel good tapping out to the strength and conditioning coach or to their personal trainer or their team trainer and saying, hey, this person checks all the boxes from a medical rehab standpoint. Now they just need to play their sport, and they just need to gradually get exposed to the sport. And in reality, there's a lot of other people that are better than myself at doing that. I played a variety of sports growing up. I didn't play any of them at the highest level. And as I got older, my skill and my sports set started to narrow. So I can only take a gymnast so far. I can only take a soccer player so far. So I think we do need to kind of keep our egos in check as well. And you start to realize, when am I as a clinician no longer the most qualified person to be given this person strength programming? When am I no longer the most qualified person to be teaching reintroduction of skills other than just making sure that they can do it from a safe standpoint? And I think that's where a little bit of self-reflection and admittedly putting yourself and surrounding yourself with people who are smarter than you and having more experience, so you start to realize kind of where you are on that continuum and where you need to grow with. I don't know if that answered your question, but I went on a nice little tangent for you.
No, definitely. I mean, there's a certain point where you just have to make that leap of faith that you're eventually going to have to hand the athlete over to another provider, professional coach. And I think you did a great job of kind of outlining like what are some objective and subjective benchmarks you can use to determine that you kind of did your job. Because yeah, at a certain point you have to trust your preparation, your athlete's preparation, and like someone else is going to have to do the rest of the sport specific progression. Like just, I don't think it's realistic to expect physical therapists in an outpatient clinic to totally reproduce a sporting environment. So no, that was, I don't know if you guys have anything to add, but that was,
No, I think
that was a great
like,
answer.
Like you gave such a great example of a very extensive like testing battery that really covers like all of the basic qualities that an athlete needs to ultimately like, be safe to get back to their sport. And I would say like be safe and effective, because I like the point that you brought up before about like are you up to the level of your competition? And that was something I heard Rob Panarello say first, was like, can you, like where do you stack amongst your peers? Because I think we've all, anecdotally have heard those stories of athletes that like got cleared to go back to the sport, and they're like, oh man, it took me like 2 years before I felt like I was the same again. It's like, that's probably not just like, oh, time, it just takes 2 years for you to feel normal again. It's like you've been saying this whole time, Zach. It's like you didn't do the foundational things early on and go through the appropriate progression of activities to actually like be able to be confident, to actually be able to play amongst your peers in a way that is safe, but you are still like able to like be a productive member of the team. Because again, lots of people get cleared, but they don't feel like they're themselves again. So that definitely takes time, but it can take less time if you're going through such an extensive rehab protocol like you've been talking about this entire time.
And I think it's also where people always ask, like, how long does ACL rehab take? And we just talked about, think of all the different boxes you have to check. And when you talk about that 9 to 12 month mark, it can happen in 9 to 12 months mark, that 9 to 12 month mark, assuming you're doing all the right stuff from day one. But the more boxes you miss early on, it has a compounding effect, because everything you're trying to do later on is dependent on that prerequisite skill. And if we miss that skill early on, now we've got to backtrack and get it again. And it just has this massive compounding effect. And I think the fact that we're even having this conversation is a win for the physical therapy profession, because it wasn't long ago that the study came out that showed, it was something ridiculous, like 88% of this cohort of athletes that they surveyed going back to return to sport testing didn't have any sort of functional testing at all. It was, hey, you hit this time mark, you're able to go back. And it was only 12% went through any sort of functional testing. And when I say functional testing, it was extremely underwhelming what they cited as well. It wasn't even, I would say, half of the stuff that we talked about. And of those 12% that did the testing, it was another small fraction that actually passed any of it. So you wonder, people always say, like, why are we tearing so many ACLs? And why? I always say the number one thing is just exposure. Every time you step on a field, you are at risk for an injury. And if we're playing multiple sports and we're playing multiple competitive seasons throughout the year, then every time you're going to be in exposure. And the more times we put people who are ill prepared in those situations, the higher likelihood of the re-tear. And I think I rattled off a wide variety of tests that we do. I don't want people to have the impression that we do all of those at the end. It's stuff that happens throughout the process. So it's not even really obtrusive to your ability to get through a session with them, because you're checking off those boxes along the way. And it's one of those things, Josh Funk always calls it, capture and keep. Early on, you capture this quality, your range of motion, some of the prerequisite strength. We no longer have to keep filling that bucket and just watching the water spill over the edge of the bucket. We just have to do the bare minimum to maintain that quality as we start targeting other areas of interest later on in the program. So, we talked about like 12 to 14 different things that we look at, but some of them we're capturing in the first month and then we don't care about them anymore. The next one we're capturing in that 8 to 12 week frame, and then that's old news and we're going on to something else. And half of them are part of your flow sheet that you're doing with them anyways in the weight room. So just watching them observe it in a strength training session, you've done the test itself.
I was just going to say that if you're going to do a broad jump test, it's like, you're not just going to do a broad jump test. It's like, this is the first time you're broad jumping. Like, you're going to have already been doing a boatload of jumping. You've probably already been doing broad jumps for a while. And that's definitely part of it too, is like a lot of these tests are exercises, and other people have said, the test is the exercise is the test. It's all the same. So it's definitely something that should just be built into a normal program anyway.
Yeah, I think it's really important when you talked about, like, can the athlete meet the demands of a game? And from a testing standpoint, even in like change of direction, it's much easier to standardize predictable change of direction testing. So like to have like a perceptual test is much harder to standardize, because that, relies on a reactive component, and it's hard to like recreate that every time. But like, we know from people can criticize the NFL Combine, but we know like there's years of data on the 5-10-5 for various positions. So if you're rehabbing, like say like an NFL level, receiver or DB, like if they are so far outside of the range of what's considered good or acceptable in a 5-10-5 for that position, regardless of your quad symmetry and all these things, like they can't meet the demands of the game. Even a 40, it's a linear test, but like if you're training an NFL receiver and like at the end of the rehab, they're running a 5-second 40, that's like a big red flag, right? So we have data on this stuff, and no one's saying that like you shouldn't do other things, but you need to meet the demands of the sport. And oftentimes that testing requires very predictable type environments. It doesn't mean that that's the only thing you're going to do, but like we have data out there. So we need to compare athletes to their peers and not just like, do these like very, very individualized type of scenarios.
And I think that it takes the emotional involvement out of the decision making as well. And I think that's something where I had an athlete and I pulled the 300-yard shuttle. There was a research study I found where they looked at Division I men's and women's collegiate basketball, and they looked at Division I baseball and softball. And they took all of the athletes that were in that test and they put them in the 90th, 80th, 70th, all the way down to 10th percentile based on their 300-yard shuttle. And I had a college basketball player at the time who was about 8-9 months out ACL. She wanted to start being more and more involved in practice, doing scrimmaging, things along those lines. And we had been incorporating the 300-yard shuttle as part of our weekly linear conditioning that we did. And she was in like the 20th percentile. And I told her, I'm like, hey, you have all these other tests look good. You're getting further and further from surgery. It's logical to start doing some reintegration of sport-specific tasks. Your range of motion looks good. Your strength looks good. But you're not going to be able to run up and down the court. You're going to go 3 times up and down the court, and then you're not going to be able to hang with anybody anymore. So I think from a performance standpoint, it makes that conversation easier as well when people start hitting these other criteria to return to sport. And you can almost humble them that, hey, maybe you're not as ready as you thought you were. And you can go back out on the field, and from a medical standpoint, you are cleared to play, but you're going to be a shell of your former self trying to cover somebody. Like you said, you're a DB and your 5.10.5 is 0.2 of a second slower than what it used to be. Good luck trying to cover anybody.
Definitely. Yeah, I think we could probably keep talking and go on different tangents with this. We've taken so much of your time already. We're very appreciative of you coming on. We'll definitely have to do something like this again down the road, maybe find something else to get angry about, talk about.
No, I appreciate you guys invite me out and be able to talk shop a little bit. And I think these are the conversations where whenever we go out and teach courses, I typically tell people there's not like there are some wrong answers, but there's not a gold standard answer to them. But I think the more you can learn to play devil's advocate to both sides of the argument, it puts you in a situation where you can explain your intent and your rationale for a drill or an activity to a patient, to a colleague, to another medical professional, to mom and dad. And I think the better you can articulate it, you can learn to speak the language of whatever audience you're trying to convey that message to.
That's a great message for sure to kind of wrap up and summarize everything. Absolutely. Thanks for jumping on with us, Zach. We really appreciate it.
Yeah, thanks, Zach.
Thanks, Zach. Thanks for everybody for listening, and we'll see you next time.
Thanks, everybody.
Thank you for listening to the Resilient Performance Podcast. For 10% off our continuing education membership platform, please use promo code PODCAST at our website, resilientperformance.com, and be sure to join our mailing list for monthly exclusive content.